forward. Hello, everybody. Welcome back to our seminar series. I'm Jim Karinji, Professor of Public Health here, the School of Community and Public Health Sciences. Today we are extra lucky because we have a really great expert to be talking about the topic, but also we're super proud to have one of our graduates from the school Master of Public Health program, Julia Goar, who is also a certified EMT, and she's the Public Health Emergency Preparedness Coordinator for Missoula Public Health. And the title of her presentation is An Introduction to the PHP Public Health Emergency Preparedness Program. So,
sweet,
Julia, thank you.
Thank you.
We'll have questions at the end.
Great, thanks for that introduction. And I can't really see much online. Oh, I see I have some participants. So if you have any questions, you can just interrupt me whenever. So I am a double alumni of the University of Montana. I am very proud to have come here for my master's program, but I also have a bachelor's degree in health and human performance. And as Jim said, I am currently the Public Health Emergency Preparedness Coordinator at Missoula Public Health, formerly known as the Health Department. We just did a big rebrand. And I'm also an EMT with the Mobile Support Team, and that's through Missoula City Fire Department and Partnership Health Center. And if you have questions about that, I can answer that at the end. It's a very cool opportunity for me. So there's not very many people in this room, but have you guys heard of PHEP before? Public Health Emergency Preparedness? Curtis, have you?
I have, not in the context of local public health.
Okay, because you're a CD alum, so I would imagine that you have. Have any of you guys in the back? You have, amazing. So we're kind of split. Before COVID happened, I had never heard of PHEP before. And like I said, I have 2 degrees in community and public health. I've worked in all sorts of different contexts. I've worked in research, I've worked in education, and I had hardly even heard of FEMA before PHEP and before COVID. And that might just be me, but I wanted to share at this seminar series what I have learned in the last year of my employment at Missoula Public Health. So this is what we're going to be going through: a quick definition, history, what it looks like in Missoula, my partnerships, my current projects, and my future goals. For those of us in this room and online, please take care of yourself during this presentation. Crisis and emergency work is not easy. So if any of this stuff makes you feel uncomfortable, if you're like, wow, I haven't thought about that in a long time, I need to go get a drink of water, that's totally fine. It's hard for me sometimes too. So what is public health emergency preparedness? It's just as it sounds. It is public health. Sometimes emergencies happen. Sometimes those emergencies or crises or incidents, events, whatever you want to call it, affect our health and the public health. And what are we doing to prepare for that, mitigate that? So I have a wheel kind of behind this. It says prevention, mitigation, preparedness, response, and recovery. And this is the phases of emergency management, and that's what public health utilizes. So PHEP helps health departments build and strengthen their abilities to effectively respond to a range of public health threats, which you can kind of think about that in your own mind, but I will provide lots of examples going through this presentation. Here in Montana, the Department of Public Health and Human Services supports us and has leadership in collaborative partnerships. So we'll talk about this a little bit more as we go on, but my boss's boss is DPHHS. So the history. So public health and emergency management have been here for a long time, even before those terms were in our vernacular. We've had things like yellow fever, smallpox, HIV/AIDS, terrorist attacks that people have been responding to, whether they be nurses or public health officials, doctors, police, whoever they may be. They've been in this for a long time, but it all kind of came to a head during the 9/11 terrorist attacks. We had this huge event that affected a lot of people over many jurisdictions. So not just in New York, but DC and Virginia, and everybody wanted to help and all the responders were activated. It was kind of a mess. Not that anyone didn't do their job well, but we didn't have a great coordinated effort for a specific incident like that. So out of 9/11, if you don't remember, that's where Homeland Security as an apparatus of the government came to be. And then the wide scale adoption of the National Incident Management System, which is NIMS. I'll really try not to use too many acronyms, but PHEP, NIMS, and ICS are the three I'm going to use. Public Health Emergency Preparedness, National Incident Management System, and then, yes, so that was implemented during that time, and public health emergency preparedness started to be funded as well, because the government thought, wow, this was a big deal. We didn't do the best job responding to it because we weren't very prepared. We should start prevention programs all over the country. So that's basically where that came from. ICS was the other one that slipped my mind a moment ago. So this is the incident command structure. If you've never seen this, I'm really happy for you because that means you've never had to use it. But this is what we use in COVID and other incidents across the country, whether it's Katrina or, like I said, COVID or a fire here in Montana. We all use the same structure, the same language now versus before 9/11. So we have incident commander and the command staff at the top. We have operations, planning, logistics, and finance. Not going to get into it a lot. Operations does the stuff, planning plans the stuff, logistics gets the stuff, and finance pays for the stuff, is basically how that works. Just wanted to give you a background on that. So in Montana, the PHEP program, again, is a cooperative agreement. So again, like I just said, the feds decided this was a good idea. They give money to the state. The state then supports local and territorial public health departments ever since 2002. And public health hazards in Montana can come from a lot of arrays, but these are just some examples. So communicable disease outbreaks like we've seen in COVID, and last week we were talking about, which disease was it? Syphilis. That was a quiz. Thank you. Syphilis. Yeah. So whatever kind of communicable disease outbreak is happening in this moment. Food and water contamination. We grow a lot of food here. We have a lot of major watersheds here. So that can be a big deal. Chemical spills. We had a couple train derailments over the last few years. One just had beer in it, maybe not such a big deal, but the other one had fuel in it down in the Yellowstone. So that was definitely a big deal. Wildfires and smoke. Every year, it's something that we talk about all the time in public health, especially here at the U. There's lots of research going into that. And then, of course, just everything that nature throws at us: drought, flooding, earthquakes, tornadoes, avalanches. These are all things that have happened in Montana that can affect the public's health. So these are the core capabilities of public health. I'll kind of go through them quickly and maybe give you some examples of some things that I think about or I would work on in these situations. And then I'll give you more specific examples of what I do at Missoula Public Health. So community preparedness, all emergency preparedness starts at home. What are you doing with your family, your pets, your kids when something goes wrong? And that does spill out into the community. What's our community evacuation plan? Do we have enough buses to get people there, etc.? After the dust settles and things get back to normal, community recovery. Think about what that might look like for something like COVID that's kind of complex versus an earthquake that just, you know, the city's gone and we got to rebuild it. After something like COVID, it's like, well, how do we rebuild our community and our brains after COVID? And how are we going to do things differently that they're safer? So recovery is a big piece of that wheel that I showed you earlier. Emergency operations coordination. So that's why I showed you that org chart. That's something that I have participated in. During COVID, I helped run testing. So that was ops. I was part of the ops team. Information and warning. How do we get the word out to people? You know, where do I go during a fire? Do I still need a mask when I go to school? Things like that. Fatality management, mass care, and medical surge, I feel like all kind of go together. If we have a major incident where we have mass casualties, what are we doing with the bodies of those folks? How are we caring for survivors? Is our medical system ready for a surge? So I work with our hospitals a lot to try to plan. They have their own emergency plan and management folks, but we work together very closely. So if something like that happens, we're able to you coordinate care, even if it's something like a car accident that's like a 5-car, you know, that can get a lot of people into your ICU or your ER. So it doesn't have to be thousands of people necessarily. Information sharing, kind of talked about that with information and warning, is just so important, especially these days, that we're sharing accurate and timely information with people. Medical countermeasures, dispensing and administration. This, thinking about COVID, could be masks, could be ventilators, that goes into the medical materials, and also non-pharmaceutical interventions. Masking, evacuation, distancing, those are all things that we can do during a pandemic and airborne that can help us without medications that we did before we had vaccines and treatment, right? Lab testing. So if things are getting weird, people are getting sick off the Clark Fork, are we going to start some water sampling to see what's going on there? Let's see. Surveillance and epidemiological investigation. I'll talk a little bit later about like key surveillance partners, but making sure we have an eye on what's emerging, who's transmitting and how. I like this one as an EMT, responder safety and health. So during a public health emergency, we don't want our public health system to crumble. And during COVID, I feel like we did a pretty good job that our whole health department wasn't out sick all at the same time. And when I worked in testing, you know, we kind of looked like these people, right? The mask and the gown and the goggles. None of us got COVID during that time, even though we were exposed potentially all the time. So definitely making sure our responders and our public health officials are safe. And then volunteer management, last one, just going back to thinking about 9/11 or Katrina, or when things get weird around here. I know many years ago, we had an avalanche that took out a house in the Rattlesnake, and people just want to help, right? They show up and they're like, I'm here to help, I'm a body. And you're like, okay, that's great. Oh, where am I going to put you? And are you going to be safe? Do you have the equipment you need? What's your training? There's a lot that goes into volunteer management. So that's something that I could help with. And I try to, I'll talk about work with partners to make sure that that's happening as well. So this is kind of a look into my brain, how my brain works. I'm kind of new to PHEP. So I literally have this on a whiteboard in my office. What are some events that are most likely to take place? And we've already talked about most of these. I did add in the opioid crisis for overdosing. That's something that I think about a lot. What's the effect of these events? All sorts of things that a lot of them are pretty easy to think about. Loss of power. What if I'm a power dependent person? I have a respirator, a ventilator, or I don't live in a house that has cooling or heating. That can be a problem. Gender-based violence, we saw an increase of that during COVID because people were stuck in their house with a partner that could be hurting them. So that's something I had never really thought about. Addiction, that kind of goes into the opioid crisis. Of course, morbidity, mortality. Who is the most at risk? I feel like with my degrees and coming from the University of Montana, it's been really hammered into me to think about most at risk. Who do I need to target my interventions towards? Who needs to be at the table when we're making decisions? I co-chair Access and Functional Needs Subcommittee, so I think about those folks and just other folks who are at most risk: refugees, folks who are unhoused, queer and BIPOC folks, youth in college, also older adults, chronic illness, immunocompromised. Who else responds? I don't want to be that type of volunteer who shows up and is like, oh, people are already doing this, I'm not needed. So something my mentor says a lot is don't waste a good disaster. Get there, meet people, make partnerships, but I want to make sure that I'm not duplicating anything. So we'll talk about my partnerships a little bit later. We already kind of touched on recovery. So what does that look like? Mental health, grief. What if we have to relocate people and bring them back into their homes or rebuild things? And then with recovery and resiliency, both treatment, medications, and vaccines are things that are really helpful to us. For resiliency, this is another thing I'm very passionate about because bad things happen. whether it's just like a little fender bender, you break your ankle, or your house burns down, something is gonna be unfortunate at some point for somebody in our community. So what are we doing to plan? What am I doing to outreach, to educate folks? The built environment is something that I feel like has come up a lot pre and post COVID, but how equitable are our systems? How are our cities built? Where the buses go? You know, what percent of mobile homes are on a floodplain? These are things that I'm thinking about with the built environment. Resources, making sure people have access to things that are meaningful to them. And then again, TXRX vaccines. So that's what my brain looks like on the inside. As far as things that I specifically do in my job description at the health department, I maintain the public health directory, which doesn't sound very sexy, but it's super important. When you pick up the phone and you're like, I need the health officer now. It's Damien, what's his phone number and what's his email address, and are those up to date? Is it our last health officer? Is it the health officer for 20 years ago? No, it's not, because I've updated it, but it's very important for our communication plan for that to be intact. I help our immunization clinics track what they're injecting people with, and who and when and where. That's very important. I track staff training, so I want to make sure that our staff at the health department is trained in the incident command structure, like I showed you before. So if we have to activate that, it's not the first time they're seeing that flow chart. And our sanitarians have specific trainings that they need to do, so I make sure they're up to date on that. We do communication tests, like I was saying with the public health directory, like it's 2 a.m. on a Saturday night, who's getting a fax, who's getting a phone call. Community outreach and education, just like they're doing today, having communications and conversations with people so they start to think about what they may do in an emergency. And then I have a couple specific kits, chemical bacterial agent transport and drinking water emergency sampling kits that are like physical boxes that I maintain as well. And those are spread out throughout the community in case we need them. So kind of going back to, you don't want your system to crumble during an emergency. We have a capabilities work plan and we have an emergency operations plan. The EOP has just a basic plan. And I learned recently, and I can't remember the exact quote, but plans like these should not be specific. So if you ask me a bunch of specific questions, I might say it really depends on the emergency, because a fire in Lolo is different than a fire in the rattlesnake, right? Those are two very different things. Floods are different, diseases are different. But we have a basic plan that kind of outlines like, oh boy, this is happening. What are our first steps? What do we need to activate? What, going back to that, that flow chart, who's the incident commander, who could be in charge of these different things. Then we have functional annexes, which are a little more specific, and these are the ones that I have. Emergency risk communications, communicable disease, lab sample transport, emergency medical countermeasures, and continuity of operations. And then we have a hazard specific, and the only one that housed within me in my program is pandemic response, but we have a few others kind of spread out throughout the health department. I know we have a truck and trailer plan that lives mostly with environmental health, and I'm working with them as well with heat and wildfire smoke with a couple other agencies. So we have like specific plans for that as well. Those are the ones that I have in my files. So I do not do this work alone. I am a tiny piece of what Missoula has to offer as far as emergency planning and response. I kind of wear the public health hat at the table when I come to meetings, but there are tons of people who work in this profession. So the Regional Healthcare Coalition is one of my big partners. They oversees all the hospitals and clinics. So it's like, oh my gosh, how many ER beds do we have? I would ask them, they would know, or they know the where to go to find out the email or what have you. The Office of Emergency Management is another huge partner for me. They oversee EMS, fire, and law enforcement. They also host the local emergency preparedness committee. So bringing people together to talk about emergency preparedness at large. And like I said earlier, I chair the Access and Functional Needs Subcommittee. So that group basically works to make sure that folks with access and functional needs are baked in and built into our plans. So all of our messaging is accessible, they're in different languages, etc. Key surveillance partners, which I alluded to earlier. So who is keeping an eye out for germs and other things in the community? These are the folks who would see it first, like, oh, I got a kid with chicken pox. The schools are going to see that. Oh, we just tested positive for some exotic disease. The hospitals are going to see that, or the labs. So these are folks that we interact with a lot. University of Montana, of course, I'm here, I'm an alumni, but we also are an academic health department at MPH. So it's really important that we kind of both ways, if students and faculty want to be involved in my program or other programs, they're welcome. And otherwise, if there's research being done here that I'm like, oh, I'm really interested in that, we have that two-way communication, which is amazing. The International Rescue Committee, when it comes to, I kind of talked about language up here, but just cultural differences and specific languages that we might need to get materials translated into in all nations to make sure that we're honoring ancestral ways of knowing and that our plans and responses and communication styles are culturally appropriate. So some current projects on top of everything else that I've already kind of talked to you about that I have my fingers in. MPH just went through a big rebrand, so we're doing a lot more social media stuff. So I have this series called Let's Make a Plan, where I'm walking the public through what goes into making a personal emergency preparedness plan. You'll probably see me at a lot more community events coming up, passing out, I don't know what it'll look like, a flyer, a little plastic bag, some sort of kit to people. I think that's in my future goals are these preparedness kits. So passing those out at community events. And then I'm also working with a lot of different agencies. The health department, law enforcement, fire department, EMS, the state, we're all working together for an overdose spike response plan. Oh, that startled me. So if we do have a spike in overdoses in our community, fentanyl, what have you, we have some sort of plan for that because they kind of roll through with some regularity, but we don't really have any sort of plan, whether that be response or communication. So what we're thinking at this point is a lot of data collection. So EMS might see a rash of overdoses, they ping the state puts it in their database, they ping the health department, we put out a PSA to the community saying, hey, there's a bad batch coming through, or we get on the phone like, hey, Billings, hey, Butte, it's coming your way, be prepared. Or down in the Bitterroot as well, north south is big. So that's something I'm working on, which I'm really proud of. Future goals, besides those preparedness kits, I really try to promote Smart 911, which is a two-way system. If someone calls 911 and they have some sort of specific need or an access and functional need, they can make a profile, and so the dispatcher will see that when you call, and they can inform law enforcement, EMS, whoever's showing up to respond to your emergency. This really helps with like a fire or an incident where we're like, where are the people that need to be rescued? Where are the people who are in wheelchairs? This can kind of help map that for us. So it's kind of a two-way street. Besides just doing school presentations here at UM, I would love to get in with kids as well, because again, all this starts at home and just being aware of what you can do. And I'm hoping that more PHEP education can go into our college system, because I didn't learn about it except for maybe a chapter in environmental health about wildfires or something like that. So I would love to do that. Those are my references. And thank you all so much for being here online and in the room. I really appreciate you listening to me talk about what I'm really passionate about. It's really fun. What questions do you have? Thank you. And online, I think Jim or maybe Patrick will be monitoring. So feel free to either speak up or throw it in the chat, either way. I do a lot of online meetings, so don't worry about it.
Yeah.
Okay, yes, Curtis.
Yeah, just sort of I guess a general question. One, there is a big difference between responding to an event, an
Mhm,
acute event,
mhm.
and something that is more still an emergency, but something that plays out over a longer period of time,
An
like,
incident, as FEMA would call it.
yeah, so
Yeah.
like COVID is a good example of that, or you had up there, I believe, lack of housing.
Yes.
So, like, how difficult is it to prepare across those different kinds of, timelines of response?
Yeah, that's an excellent question. I would say it takes effort. How much? Oh, hey, Patrick. How hard is it? I don't know. Like, I don't like to look at something and be like, oh, it's too hard, I'm not gonna do it. That's not what public health is all about. You look at a situation, you're like, wow, this is really hard. How do we get her done? From my own experience as an EMT with the mobile support team, and maybe this will kind of speak to your question. We see a lot of clients who are in distress because of a behavioral mental health acute issue, but the bigger issue is housing or addiction or co-occurring disorders. So I think you do just really have to take a public health approach, and that's why I really like this field, is I'm often in the room with firefighters and police officers who just want to respond to this acute moment when there is planning that needs to be done. There's coalitions that need to be built, getting our local leaders involved and thinking about these things. It has a huge trickle down effect. I feel like public health emergency preparedness isn't that much different than just public health in general. You're trying to make a healthier environment that's more accessible to everybody. I don't know if that answers your question, but there are two different levels, I guess, two different timelines. And I work in both because I enjoy them both. And I think having that context is really helpful. Yeah.
I was just gonna ask, what do you feel like is going well in Missoula right now? And what do you feel like is the kind of biggest gap or an area where you'd like to see change or improvement?
That is a great question. I think what's going well is that I'm not the smartest person in the room. Like, there are so many people that have so much good experience, mostly in wildfire. I think we do fires really well around here. Like, we respond, we know they're gonna happen, we have the weather service in the room, we kind of know what's gonna happen, it pops off, we get there, we have a plan, we're either gonna let it burn or not. We've been doing fire for a long time, so I think a lot of the baseline knowledge comes out of fire, which is very helpful. Lots of good experience. What's the greatest gap? Maybe what Curtis was talking about, having more integrated health at every level, including emergency preparedness, making sure that all of our plans are equitable and addressing challenges that people face every day, like being unhoused or, inflation, who can afford to feed themselves even? It's tough. So how do we make a more stable structure for a blue sky day so that when things get bad, we're more resilient? Yes.
So, what would be a way that, the public could respond in a helpful way? Because you gave some examples about, and I've been that guy, in Homer, Alaska, showing up to a fire in my,
Sure.
My, fleece pants, and having the firefighters go, get out of here.
Get out. It's gonna melt to you.
Yeah, so, that's a very dumb example of me, but what are some things that we could do, and,
Yeah.
and then maybe even specifically our students here at the university, our campus,
Yes.
things like that.
Yeah, so there is a health professional registry, like volunteer registry through the state. If you kind of Google those words, I'm sure it'll come up. So if you are a nurse, doctor, EMT, paramedic, whatever that looks like, you can go that route. I would get a hold of just like your local Red Cross. If something really acutely happened, I get a hold of them. We utilize them a lot is for sheltering and things like that. I think most of the shuffling people out of an area, I think we got that covered. So try to ask yourself, am I actually gonna be useful in this space, depending on my skill? And then, yeah, I would go to either Red Cross or, that registry. Another thing you can do, it's not the most like exciting thing in the world for most people, it is for me, but going on the FEMA website and training yourself in some ICS. It's really, I find it really interesting. I think a lot of people find it really dry. It is a government training, so it is, you know, kind of black and white and lots of slides, but yeah, just familiarizing yourself with that structure can be helpful. I would say with students as well, I mean, you can contact me or the health department in general if you're looking for some kind of project. We also have an all hazard incident management team in Western Montana here in Missoula. So if you have a fire background and you kind of know about ICS, or this is really interesting to you, they do a lot of trainings and a lot of like field work, which is really cool.
Thank you.
Those are all I have off the top of my head.
Yes, I have one more. So thinking of what you said, so one of my interests is secondary traumatic stress. So, you know, the impact of trauma, what you experience would be primary.
Yeah.
However, what role does like critical incident stress management or anything like that play in your world, Julia? Do you have access to those things?
Could you say like the term again, critical?
Critical incident stress debriefing or critical incident
Yes.
stress management.
Yes.
The fire departments usually
Yes.
have things like that.
Yeah, so in my EMT life, our team does a really good job about debriefing, and we have a lot of benefits that help us with counseling and other things. So that's really awesome. On the flip side, though, I would say during COVID, when working in COVID for the health department, it was kind of a little too late kind of thing. Like, gosh, it was like November of 2020 before it's like, oh, you can access counseling, and we're like, or like stress relief classes, and it's like, I don't have time for that. Like, I'm working 80 hours a week, and like, and then you go home and you got to put a mask to go into the grocery store, you know, whatever. I think COVID is a very interesting topic when it comes to that. And I think that's why I was kind of talking about with recovery and resiliency, and something I try to think about, at least in my job. I don't know how to necessarily do it, but how do we build a resilient, strong community? So when things do go badly or something like COVID happens, where we have, you know, mass trauma at all sorts of levels, all throughout our community, we were all traumatized by that event in one way or another. How do we recover from that? How do we rebuild from that? I don't know the answer, but that is something I try to think about, and I try to think about when I'm writing a plan too, to have that piece in there. Not just like, okay, we showed up, we put out the fire, let's get the heck out of here. Like, what's that next step?
Thank you.
Yeah. Do you have another question too?
Well, just a follow-up to the question about gaps.
Mhm.
And I have a thought on that. I'd love to hear your thoughts.
Yes.
On this. So I feel that one big gap for preparedness
Mhm.
is data. And I'll
Oh,
give you two
yeah.
examples. One is very obvious. In the COVID days, we had a severe lack of data. And
Mhm.
Missoula wound up doing a great job with their incident command structure. They
Mhm.
were able to get data from hospitals and schools.
Mhm.
But all of that was a really initially clunky process that took a lot of work and resources,
Yeah.
whereas that data should be just readily available, right? Like, we shouldn't have to go to Johns Hopkins website to figure out how much COVID there is in Montana, right?
Yeah.
So that's one example. The other
Yeah.
one, since you brought up fires, I would add to that like extreme heat, or at least like sort of
Yes.
climate extreme events. And
Yes.
wouldn't it be great for your program and others to have access to where the vulnerable people are? Like, who has
Yes.
COPD
Yes.
and is a single home dweller, or, you know, like
Yes.
like living alone?
Yes.
Who doesn't have access to you know, energy or air filters or cooling?
Mhm.
So just throwing that out there.
Yes.
What could be done about that?
I agree, first of all. Some of the mapping, I'm wondering how much of that could come from Smart 911 if more people enrolled. So that's something that I've been working with Office of Emergency Management on. I know, like, maybe not Red Cross, but there are some other bundles of data that have folks with access and functional needs, which is important, like you were just saying. But I agree with you. Gosh, I feel like lately data is just like the bane of my existence, because it's what do we have and where is it and how do we use it? And I think that's a health department wide problem right now. Besides just our cute new brand and stuff, we are going through a huge restructuring ever since Damien became our new health officer, which I think is amazing. I think it's a very positive thing. Also a UM alumni, so really great. But we are restructuring and rethinking about how we are storing our data, what data is out there. And if Johns Hopkins has something, or the wildland fire folks have stuff, where can it all come together and live in one space? That is something we are working on, and it would be beneficial for every single, not just me, but everybody at the health department and everybody at UM too, if we were able to data share better. I think that's something that we could do and do better. 2 new positions at the health department came out of COVID. One was a PIO, a public information officer, and the other was an epidemiologist, a full-time epidemiologist. So that is definitely something she's been working on internally. We're going to work externally, but I completely agree with you. And that's something that, again, like has been on my mind a lot, of how the emergency world and how public health come together. Because during COVID, I think we did a decent job in some of it, and some of it was incredibly clunky, and some people didn't want to play together. And that's okay. That's always going to happen within an incident. People have big feelings and jobs and families and things they worry about. But that's something I'm probably going to continue to explore. I'll come back next year and report back, because I'm year 1 into this position. And I feel like I've learned so much just in that time, but it is something I'm always thinking about, how those 2 worlds come together, because they are kind of just different in personality and discipline.
So Damien and I would like a date. When do you want to come back?
Yeah, I
Just
can come in
kidding,
the
just kidding.
spring.
We'll talk.
Yeah, I can come in the spring, or maybe I'll teach a class. I have to go talk to Patrick after this. Shameless plug. Come sign up for my class. Yeah, any other questions? Oh, there's a chat, but I think that's just on my end,
Yeah.
that it's your chat.
It was just me asking.
Cool.
Yeah.
Thank you for all of you that came online. I really appreciate it.
Yeah, thanks, Joe.
Thank you, Julia.
Thanks, Julia. Good job.
Thank you.